All right, welcome to the last lecture of the class. We're going to talk just a little bit more about some disorders, and then we're going to finish up with just a short little recap of some different types of therapy. So, we've talked about anxiety disorders, eating disorders, briefly touched on sexual disorders. There's a lot more out there than just fetishisms or erectile dysfunction, but those are the only ones that we're going to cover in this class. If that's something that you're interested in, there's definitely other classes at UWF that you can seek out. We're going to finish up today with mood disorders and schizophrenia. So, what are mood disorders? That's what we're going to start with. These are the emotional extremes, the highs that are too high, the lows that are too low. Remember, we have to think of clinical disorders in terms of maladaptive behavior. We all get happy sometimes. We all get sad sometimes. That's totally normal. But there is a point where you can get too sad or too happy, and that actually becomes harmful behavior. So, we're going to talk about major depressive disorder and bipolar disorder. These are the two disorders under that umbrella term of mood disorder. First up is major depressive disorder. This is the most common mental disorder in the United States. And some of the symptoms that you see at the bottom of the slide there, you might be familiar with some of these symptoms. You might know someone who suffers from depression, or maybe you suffer from depression yourself. Some of the symptoms there might not be all that surprising. Your mood is severely depressed. Your interest in normal hobbies and activities that you used to take joy in is no longer there, so you lose that interest. We usually see a change in weight or appetite, see a change in sleep patterns, either sleeping too much or sleeping too little, loss of concentration, and sometimes suicidal thoughts and ideation. So, again, if you have several of these symptoms and they are present for greater than 2 weeks, and that is a contentious part of this diagnosis, is that these symptoms have to be present for more than 2 weeks before that label of major depressive disorder can be applied. So, those are some of the classic symptoms, have to persist for greater than 2 weeks. Depression is something that occurs around the world in many different cultures, but it seems to be something that affects Western cultures more than other cultures. So, by Western, I mean US, Canada, Europe, Western Europe, Northern Europe, Central Europe, those types of Australia, I guess, as well. You can throw that in there. Those are your classic Western cultures, and it seems to be more prevalent in those cultures, which tend to be a little more individualistic. There's not as many social safeguards, social safety nets, so everyone's a little bit more on their own in a Western culture as compared to something like an Eastern culture. So looking at this graph here on the y-axis, we have percentage of people experiencing major depression at some point in their life. We have 0%, and it goes all the way up to, I would say that's probably 25%. The blue bars represent males, the red bars represent females, and on the x-axis we have different cities and countries that this data is taken from. USA, Edmonton, Alberta, Puerto Rico, Paris, Germany, so on and so forth. And you can see again in every culture or in every city or country here, we see that the red bar is higher than the blue bar. So major depressive disorder is something that affects women or affects females more than it affects males. That is a cross-cultural finding. But take a look at Taiwan and Korea, two non-Western cultures, and we see that these bars are a lot lower than they are in the Western cultures here. except for Beirut, I guess. All right, here's another graph with some data on major depressive disorder. Once again, we've got a difference between males and females. There seems to be a higher percentage of females than males on this graph. But one thing to note on this graph, on the x-axis, we have age in years, and that we see a sort of inverted U shape for both males and females. So starting at the leftern's not a word, the left side of the graph, we see that there is a lower percentage of people who suffer from depression, and then it increases, but it eventually plateaus somewhere in our mid-20s, and then in our mid to late 30s, it actually starts to decline. This is something that we found time and time again, that depression actually decreases as we get older past that mid to late 30s age. Okay, so that's major depression. Let's talk about mania. This is, in a lot of ways, the opposite of depression. This is something that people experience, and some of the symptoms are euphoria, hyperactivity, optimism, I would say over optimism. And, that doesn't sound that bad. Being euphoric sounds pretty good. Being hyperactive, I don't know. Sometimes I wish I had that kind of energy. And what the heck is wrong with being optimistic? Well, this becomes a problem because people will often engage in reckless behavior as a result. They're overly optimistic. They're hyperactive to a fault. Their sense of euphoria is not rooted in reality. So some of the reckless behavior they might engage in would be gambling or having unprotected sex with strangers, putting themselves at risk for bodily harm. So we have major depressive disorder, and then we briefly talked about mania, and switching between the two is a pretty classical symptom of bipolar disorder. So in bipolar disorder, we have a patient who will alternate between depressive episodes and manic episodes. Now, just a brief little note here. Back in the mid 90s, the definition of bipolar disorder was changed. And around that same time, we saw a 4,000% increase in bipolar diagnoses for people 19 years old and under. Now, does this mean that there was a 4,000% increase in the amount of bipolar disorder in this country? No, that is simply an artifact of the changes to the classification, which I would argue, something's up there if you can change the definition and we have a 4,000% increase. I mean, 19 and under, that includes, people in their prime teenage years, 15, 16. That's definitely a time when you're kind of trying to figure out your emotions. You're trying to figure out how to act socially, where you belong socially. It really doesn't surprise me that, during those peak teenage years, you might experience some depressive and manic episodes. But this is not something that exists in a purely mental state. Bipolar disorder is something that has a biological cause. So taking a look at the bottom of the slide here, we've got 3 different PET scans, and the darker the red and yellow, that indicates high activity, and the dark blue and the green, that indicates low activity. So here we have an individual who's suffering from major depression, and they took a PET scan, and you can see that there's not a lot of activity going on in the brain. Here is someone suffering from a manic episode, and they took a PET scan, and you can see there's a lot of activity going on. That brain is a hyperactive brain right there. And then they'll switch back eventually to the depressed state where there's not a whole lot going on. So that's the PET scan version of bipolar disorder. All right, so that's mood disorders, and then I want to finish up with schizophrenia. Schizophrenia, all right, this is originally this was meant to mean a split mind. I don't know if that's Latin or Greek, but that is the original definition of the term schizophrenia. So, schizophrenia is actually a group of disorders, it's not a single disorder. And this group is characterized by disorganized and delusional thinking, disturbed or imaginary perceptions. This would be your hallucinations, and inappropriate emotions and actions. So, these are some of the common symptoms we see within this group here. And we'll talk about these in a little bit more detail. So, first we have to define a couple terms. The difference between delusions and hallucinations. So, a delusion is a false belief. Usually, these beliefs are of persecution, so they're paranoid that someone is out to get them, or if it's not someone, it's some organization, maybe a government organization like the CIA is listening in, or the FBI is out to get you, or maybe aliens are out to get you. Or it could be a false belief of grandeur that you are somehow special, that you are important for some purpose, and as a result, maybe you're being persecuted for that. So, delusions are a false belief. A hallucination is a false perception. So, a hallucination is a perception that occurs without sensory stimulation. You hear things even though there was no sound present. You see things even though that object does not exist. So, a hallucination is a false perception, a delusion is a false belief. So, the different types of schizophrenia, we've got paranoid schizophrenia, disorganized schizophrenia, catatonic, and then sort of our miscellaneous category, the undifferentiated schizophrenia. Paranoid schizophrenia, this is characterized by delusions or hallucinations of persecution. Uh, this is often portrayed in movies and TV shows. The paranoid schizophrenic, maybe they have like a tinfoil hat on or something, and they think that the CIA is listening to their thoughts or something like that. Delusions of persecution, which can sometimes lead to hallucinations that, there's people attacking you or just around the corner trying to attack you or something like that. Disorganized schizophrenia, this is not portrayed in movies and TV shows nearly as much as paranoid schizophrenia. Disorganized schizophrenia is characterized by speech or behavior that is flat or inappropriate, and same with emotion. So the key word here is inappropriate. So maybe they're laughing at a funeral, or if they're in a social setting where everyone's having a good time, maybe they're just extremely flat affect. Their speech might be a little strange. Their behavior might be a little strange. And again, I can't stress this enough, but there's a clear distinction between what meets the clinical definition of schizophrenia and what is just normal behavior. I would say everyone in this class has behaved a little strangely in a social setting at one point in their life, or maybe they've spoken a little strangely to a stranger. They said something that they kind of regretted later on, or they feel like they act like a fool. That is not a symptom of disorganized schizophrenia. This disorganized schizophrenia symptom of acting strangely or speaking strangely, this is something that is very bizarre, very noticeable, and is persistent, and it's maladaptive. It's starting to affect the relationships that this person has. After disorganized schizophrenia, we have catatonic. This is characterized by physical restrictions in their movement. So, immobility. A catatonic schizophrenic sometimes has to be strapped into a wheelchair and moved around because they cannot move on their own. Or it could be the opposite. It could be excessive, repetitive, or even imitative movement. So they see someone waving their arms around and they wave their arms around in the exact same way, and they do it repetitively. The key neurotransmitter here is dopamine. If you remember all the way back to one of our earlier lectures, we talked about the role that dopamine plays in schizophrenia and Parkinson's. And then our last category there, undifferentiated. People who are in this category, they may be experiencing symptoms from several different of the subtypes listed there. Schizophrenia seems to have a pretty strong genetic component to it. Here we have data from studies looking at the prevalence of schizophrenia between fraternal twins and identical twins. So the fraternal twins are in blue and the identical twins are in red. And you can see in every single instance where this was measured and compared, identical twins had a much higher prevalence of schizophrenia if one of the twins had schizophrenia. So definitely a genetic component behind schizophrenia. I've got a video linked on the Canvas website. It is a short video of Anderson Cooper, who's a CNN correspondent, and he is going through a little simulation of what it's like to experience schizophrenia. And he tries to go about his normal day while experiencing hallucinations. And he actually starts to kind of experience some delusions as well. These types of simulators are often used by clinicians to help them gain some empathy for their patients, because these symptoms of schizophrenia, like hallucinations and delusions, they seem very bizarre on the surface, and it can actually be pretty hard for therapists and clinicians to help these people if they don't really truly understand what it is that they're experiencing. So going through these little simulators can actually help the therapist give better care. All right, so that's all the different disorders now. And for the next few slides, I have some short little descriptions of case studies. And these are a great way to kind of test yourself just to see how well you understand the different disorders that we've gone through. This is not, in any way indicative of what a clinician does. So don't think that you can, go around in your daily life and just start pointing out to your friends and family members like, oh, I think this person has major depressive disorder. Oh, I think this person has schizophrenia. That's definitely not what I'm trying to get across with this little exercise. This is simply a nice little study aid. All right, so I'm going to read through the description. Go ahead and pause the video after I read through it. So if you don't want me to give away the answer, if you want to try to guess what it is this person has without me saying the answer. All right, so you see Jill, who is 24 years old, in the emergency room of a hospital where her parents have brought her for evaluation. They are worried because she is giving away all of her possessions and says she is planning to move to Seattle so she can save the world. Her parents say that she has hardly been sleeping at all, but she seems very energetic. They say she has appeared to be in a frenzy lately. When you interview Jill, you notice that she speaks very rapidly. It is hard to get her to be quiet long enough for you to ask questions. She seems agitated and has difficulty sitting still. Go ahead and pause it. And this would be an example of a manic episode. Quite possibly, Jill is suffering from bipolar disorder, but this is definitely an example of a mania or a manic episode. All right, next one. Morris has been referred to you for psychotherapy following a suicide attempt. When you interview him, he is very teary. He speaks slowly and looks down at the ground as he speaks. He reports difficulty in falling asleep and staying asleep for the past month. Morris states that he hasn't had much of an appetite and has lost 15 pounds. He reports that things he used to like just don't seem enjoyable anymore, and he thinks that life is not worth living. Morris doesn't expect things to improve in the future, which is why he tried to kill himself. Go ahead and pause it. And this would be an example of major depressive disorder. The symptoms that he listed, and a key point here is that they have been persistent for the last month. So they're over that 2-week threshold. Next one. Lenore has been feeling very sad since her husband died 12 days ago. She has eaten very little and has difficulty sleeping. She is weepy most of the time. Lenore is preoccupied with thoughts of her dead husband and does not want to do much other than think about him. She has declined all invitations by friends and spends most of her time alone. All right, go ahead and pause it. So this is kind of a trick question. This does not meet our clinical definition of major depressive disorder, even though she is presenting a lot of the same symptoms. But the key criteria here is that she's only been experiencing these symptoms for 12 days. She has not passed that 2-week threshold for the clinical definition. Now, this brings up another point of just what exactly that 2-week threshold does. Lenore's behavior seems very normal. Her husband died, and she is sad about it for 12 days. That seems like incredibly normal behavior to me, a very honest, normal reaction to a traumatic event like that. So if she experiences these symptoms for 2 days more, then she can get that clinical label of major depressive disorder. So you kind of see how this gets a little fuzzy. There's kind of a gray area here. All right, next one. Amy, age 38, is a worrier. She is restless, irritable, and has difficulty concentrating. She worries that she worries so much and isn't always sure what it is that she's worried about. She can't let her husband or children leave the house without making them call her regularly to reassure her that they are okay. Her husband is growing weary of her fretting. Her children can't understand what all the fuss is about. Their impatience with her only makes her worry more. Go ahead and pause it. And this is an example of generalized anxiety disorder. Amy can't put her finger on what it is she's worried about. It's that general sense of dread. So there's nothing specific that she has to be a source of anxiety. It's just sort of life in general that she's worried about. All right, next one. Bert is 40 years old and works on an assembly line in a brush factory. He is terribly afraid of being contaminated by germs. He avoids shaking hands with others. He won't eat in the cafeteria. He has trouble leaving the bathroom because he isn't sure he has washed his hands well enough. Go ahead and pause it. And this would be an example of obsessive compulsive disorder, or OCD. The obsession would be thinking about germs. The compulsion would be hand washing. And it's starting to negatively affect his behavior at work because he's spending so much time in the bathroom. Next one. A 28-year-old woman was walking through her local shopping mall when she began to feel intensely anxious. The anxiety was accompanied by sensations of choking, smothering, and a sudden sense that the people in stores around her were unreal. She began to fear that she was going crazy, and the more she worried about this, the more anxious she became. A guard, seeing that she was in distress, brought her to the mall office where she was able to lie down. A few minutes later, the symptoms began to subside. She went home after leaving the mall, but she did not tell her husband what happened. A week later, she had a similar attack while she was walking down the street. She was able to reach her house, where she lay down until the attack ended. In the following 3 weeks, she had 2 or more attacks. Between attacks, she was constantly worried about having another attack. The patient was finally forced to tell her husband about the problem because she was so fearful of not being able to get help if an attack occurred that she would not leave her house alone or travel on public transportation. All right, go ahead and pause it. This poor woman is suffering from panic disorder. What she is describing are definitely panic attacks, and that's a pretty good description. Things start to feel surreal. There's a sensation of choking, smothering. You can't get a full breath. It's brought on by extreme anxiety. And then the fact that she stops going out in public because she's afraid of having a panic attack, that is definitely a key symptom here. So, panic disorder. All right, and this might be our last one here, I think. Let me check quick. Yeah, okay. This is our last one. We'll end the video on this one and then get started on the next one. So Jack graduated from high school and got a job working in a video store. After working for about 6 months, Jack began to hear voices that told him he was no good. He also began to believe that his boss was planting small video cameras in the returned tapes to catch him making mistakes. Jack became increasingly agitated at work, particularly during busy times, and began talking strangely to customers. For example, one customer asked for a tape to be reserved, and Jack indicated that the tape may not be available because it had surveillance photos of him that were being reviewed by the CIA. After about a year, Jack quit his job one night, yelling at his boss that he couldn't take the constant abuse of being watched by all the TV screens in the store and even in his own home. Go ahead and pause it. This would definitely be schizophrenia, specifically paranoid schizophrenia. Poor Jack is suffering from delusions of persecution, and he is starting to act strangely at work as a result of that. Okay, that is our last little case study to get some practice with these different disorders. And we're getting pretty close to that 30-minute time limit. So I'm going to stop this video and then we'll finish up with some discussion of different types of therapy.